So, dear Chairman, thank you very much. I would like to also thank the organizing committee, Dr. Sparias, for the kind invitation. So, I try to be fast and concise. So, this is a case of a TAVI patient with acute heart failure and non-STEMI and acute kidney injury, dealing with triple lethality. I don't have any conflict of interest to declare. So this is an 82-year-old gentleman that was presented with symptoms of chest discomfort, orthopnea, and shortness of breath at rest. He had some clinical signs of acute coronary syndrome with acute decompensation, heart failure, and pulmonary edema. On the ECG, he had evidence of widespread ischemia with the ST depression in all the precordial leads, and he had an initial troponin of approximately 12,000 and elevated NT-proBNP levels of 9,000. He also had anemia and also acute kidney injury with a creatinine of 2.7. And regarding his background, he was hypertensive, had dyslipidemia, and also insulin-dependent diabetes. And these are his drugs. So he had the initial assessment. This is his chest X-ray confirming the pulmonary edema and decompensation, and also an echocardiogram that showed critical aortic stenosis with a mean gradient of 52. So the patient underwent the initial assessment with a coronary angiogram, and we can appreciate here a very nasty coronary artery disease involving the ostium left main, severe calcification, had a long lesion extending from the ostium of the LAD far to up to the mid segments. We can appreciate the lesions in different views. And this is the right coronary artery, had some disease on the distal segments of the PDA, but nothing of particular importance. So he underwent further assessment with the CT TAVI. This is the measurements. We can see the annual area of around 500, good sinuses, good heights regarding the coronary arteries. But we also had a chance, something I do all the time, using the CT to get some information about the coronaries, and we can appreciate here that there was severe disease, severe calcifications. You see a big chunk of eccentric calcification on the ostium of the left main. So we had to deal here with a patient with critical AS, had acute instability with heart failure and also an acute coronary syndrome. So the main question was how to deal with the coronaries and whether we should do the coronaries first, followed by the TAVI, do the TAVI first, followed by the PCI, or do everything on the same time. But also had to consider his acute kidney injury. So we had to be very careful regarding the management of this case. Now, because of the main symptoms were predominantly his heart failure, and perhaps in combination with severe and critical AS that contributed to this global ischemia phenomenon and elevation of the troponin, we opted to proceed with a TAVI using a balloon expandable valve and get an easy access later on to deal with very complex coronary artery disease. So we proceed with the TAVI. This is the initial aortogram, valve positioning, and then implantation of the valve. So everything went very smoothly. We did an ejection there. We see patency of the coronaries, and this is the final result. It's a fantastic position and trace of PVL and good flow on the coronaries. So after that, as a stage procedure, we proceed to fix the coronaries, and you can appreciate here is a tough lesion, so upfront rotablation, 1.75 millimeter burr. We can see here it's careful pecking of the lesion and successful passage of the burr, and here modifying the rest of the disease. And this is the final result after putting two drug-eluting stents, 3.5 and 4 millimeters, and the final IVUS images. So as an outcome, we had a successful dealing of triple lethality, including the heart failure with aortic stenosis, the acute coronary syndrome, and also a very complex setting of coronary artery disease, including left main, severe calcification, acute kidney injury. We managed to complete the TAVI in 60 minutes using only 30 ml of contrast. The patient remained hemodynamically stable. He had successful stage IVUS guided PCI of the left main and the LAD with rod ablation. And the whole procedure was done without any mechanical support, and the patient was successfully discharged on day 5 post his index TAVI procedure. So as a conclusion, aortic stenosis, patients with aortic stenosis commonly suffer from multiple comorbidities, including complex coronary artery disease and heart failure. Decision on timing or revascularization pre, post, or during TAVI should be based on an individual basis and according to the patient's clinical status. CT TAVI analysis and other pertinent anatomical features can be used to guide us, but initial TAVI with stage PCI appears a safe option. And heart-in discussion is always essential for optimal management of patients with this complex setup. Thank you.
Thank you, Dr. Kalogeropoulos. Very difficult case, very difficult decision. Very difficult decision. Dr. Taleb?
Very good case. Congratulations. There is always the scenario when whatever you do goes really well, or if something goes wrong, then you start thinking back, should I have done this better? Obviously, it worked out well doing the TAVI first and the PCI afterwards. There are a lot of different ways to skin a cat, so some people could say hemodynamic support, yes or no, BAV first, support him, and then fix the coronaries, and then TAVI afterwards. Whether you use RODA or you use shockwave or you use something else when it is osteal disease can also be a thing of debate. It seems that whatever you did on this guy worked really well, so congratulations.
Thank you very much.
Professor Tsigas?
Okay, I believe the coexistence of various comorbidities are very common, especially in elderly patients. We have to individualize the process in these patients because there is no clear benefit to what's achieved firstly. Thank you very much.
Okay, thank you, Dr. Kalogeropoulos.
Thank you.
Let's proceed to the next session. Thank you very much.